So last but certainly not least, and I find this area one of the, I think one of the most exciting areas in terms of new insights to genetics. We have Rafik Tadros from Montreal Heart Institute, who I think we all know. He's an integral part of the HiRO team and leads HiRO HCM. So as I've said many times, so HiRO, or Rafik, spent a lot of time in Amsterdam and works closely with them. And he, in that context, has become a leader in complex genetics for multiple different inherited arrhythmias and cardiomyopathies. So I'm very excited about polygenic risk scores and interested in when are they going to reach clinical prime time. We see these great papers and when are we going to start using them. Genotype negative HCM, it's not high penetrant culprits that we haven't found. They have complex substrates. So with that, we will hand it over to Rafik to teach us all about it.
Thank you, Jason. Thanks for being here. I know you're all looking forward to my talk at 5 p.m. So I'll be very brief. So don't. We
ended with you because it was so exciting.
Oh yeah, that's right. So I'll be very brief, and I know everyone's is tired. I am tired. Very satisfied though by the content and your really great work, Jason and the team, for organizing this. I've learned a lot, and I'm satisfied. So I will be brief. I'll be skipping some slides if you don't mind. Just a brief introduction of our evolving view of human diseases as a whole. So we typically consider human disease either Mendelian genetic, complex genetic, or acquired. So Mendelian genetics, these are diseases that are caused by a rare variant or a rare pathogenic variant that we used to call mutation. Complex genetic diseases, these are diseases where family history is a risk factor, but we can't identify or put the finger on one genetic culprit. And one example of this disease is atrial fibrillation, where we know that family history increases risk, but most AF cases are not caused by a single mutation. There are exceptions, of course. And then non-genetic diseases, where these are diseases where there's no family segregation and family history is not a risk factor. And then we realize that actually things are more complicated than splitting them into 3 categories, and there's a mixture of Mendelian, non-Mendelian, and non-genetic factors for most of the diseases that we're interested in and treating in our clinics. And so different patient, different genetic architectures. The blue, dark blue is the mutation, so what we used to call monogenic or Mendelian diseases. The lighter blue are common genetic variants, so these are genetic variants that increase risk for a disease but are not by themselves sufficient to cause the disease. And then the orange are non-genetic risks. So example here, a KCNQ1 pathogenic variant carrier that takes azithromycin and has a cardiac arrest. So there is a non-genetic component to this medication. There's a complex genetic component, as we will come to it in a bit, and there's a monogenic component called the KCNQ1 mutation. There's mounting data that support this model, that I started with the model, but there's actually data to support this model. And these are mostly data from genome-wide association study that demonstrate a relatively large, is there a pointer? No. Yeah, doesn't matter. So that relatively large disease susceptibility that is caused by those common genetic variations. And this is the second column called estimated common variant heritability. This is the proportion of disease susceptibility that we think is attributable to common genetic variations. So not monogenic variants, not pathogenic variants, not a mutation, but rather the rest of the genome, or what we used to call or sometimes call genetic modifiers. So for HCM, relatively large proportion of disease susceptibility are attributable to common genetic variants, about a third. DCM, about a quarter. Long QT syndrome is much more monogenic than the others, and then Brugada is a really highly polygenic disease. Genetic testing in 2024, what are we interrogating? Only the monogenic components of this disease. We're only doing genetic testing to identify the mutation that we only find in a relatively small proportion of cases. For Brugada, it's about 15%. For long QT is higher, 80% supposedly. HCM and DCM is about a third of the cases. And so we're not yet considering those non-rare genetic variants with only a few exceptions like the KCNE1, the 85N, sorry, it's not 86, 85N. But most common genetic variants, even though we know that they're increasing risk, are not being reported because their effect size is relatively small. And how we practice cardiogenetics, at least from a genetic testing perspective, is based on some consensus statements. That's the 2022 consensus statement where there was a sentence about polygenic risk scores. There was actually a chapter on polygenic risk score, but what had been written is that in the coming years, we anticipate that polygenic risk score are likely to enter clinical practice landscape and become more widely utilized. But at present, in 2022, it seems too early, however. So I hope I'm convincing you that common genetic variants are important for our understanding of these diseases. And I hope to convince you over the next few minutes that polygenic scores as a clinical tool may be useful. We're not there yet, but we're very, very close, I think. So what are those polygenic risk scores? A polygenic score aggregates the effects of many common genetic variants into a single number. So it's kind of a biomarker, a quantitative biomarker. That's what a polygenic score is. There are synonyms. PGS is my favorite, but you could pick whatever you want. PGS, so the polygenic risk scores, are comprised of a few variants to millions of variants across the genome. And the variants and their weights in the score calculation are derived from genome-wide association studies. So I'll skip that part for the sake of time. What are the potential applications of PGS in the cardiogenetics clinic? First, to predict disease in relatives of gene-negative probands with the heritable condition. So these are more than 60% of the families, with the exception of long QT syndrome, probably, which is less than that. So the relatives of a gene-elusive cardiogenetic condition, we don't know how to screen them. We screen them, we do ECGs and echoes, and we repeat them, but we don't know how to follow them long-term and how to tailor these phenotypic screening, which could be very costly. In the HCM, for example, a large family of gene-elusive HCM, you could imagine that if the patient has 5 or 6 siblings undergoing echoes every 3 years until the age of 65, that's a lot of echoes that are probably done for not a good reason, if we can better tailor genetic risk. The second is to predict penetrance in pathogenic variant carriers, so for tailored genetic risk-based phenotypic screening. And the third, which is the most ambitious, and I'm more skeptical about, but we'll see, is to guide therapeutic preventive interventions by risk stratifying, so adding the polygenic risk score as a biomarker to the clinical risk factors that we all know. Whether we ever use polygenic risk scores for cardiogenetic conditions in a population screening level, I doubt, but maybe, who knows. So a few examples, polygenic risk score to predict Brugada syndrome. So this is a study that I completed when I was in Amsterdam with Connie Bidzina and Arthur Wilde and the group. We included 1,300 patients that underwent Ajmaline testing for suspected Brugada syndrome. They all had genotyping and a PGS calculation. And then we show that polygenic risk score is fairly good to predict patients who will have a type 1 or an Ajmaline-induced type 1 Brugada ECG with a specificity of 95% if we set the threshold to the 90th percentile, so that's 10% of the population, and a sensitivity of 99% if we set the threshold to the lower decile, so that's 10%, the lower 10% of the population. So it could potentially help us identify patients who may benefit from a diagnostic testing procainamide challenge in our setting, or Ajmaline testing in Europe. There are ongoing studies testing a more powerful PGS in a more diverse population, and we're including some patients from HiRO in that future study that we're finalizing. I think the most exciting disease from a polygenic risk score perspective is hypertrophic cardiomyopathy. We've published genome-wide association studies in 2021, and we had shown at that time in a in a proof of concept study that if we take about 300 patients that carry sarcomeric variants and we calculate their polygenic risk score, which was derived from the genome-wide association study, we're able to identify patients that have a higher risk of clinical events compared to, if we look at the high PGS. So the high PGS is dark red, low PGS is orange, and we see that separation of curves. The separation is not super wide. I look at the mice studies in the gene therapy. And these are Kaplan-Meier curves that are impressive. So for that, it's not much impressive. The only comment I would make here is that PGS, they're generally very useful at the extremes. So between the 10th percentile and the 90th percentile, nothing much is happening. And where you go into the extreme, this is where it becomes very interesting from a prediction perspective. Given the small sample size here, we could not divide them into deciles. The sample size was relatively small, but we're doing it now for larger sample set. We also published another genome-wide association study that's currently in press, and an accompanying paper about the potential of risk scores for hypertrophic cardiomyopathy. This is actually one of my favorite HCM genomics paper. It was led by Sean Zhang, who's a PhD student in James Ware group at the Imperial College. The paper is in preprint and is currently in press in Nature Genetics. So where they looked at, they derived the polygenic risk score from our genome-wide association study, including 6,000 cases and 70,000 controls roughly. And they tested the potential of the polygenic score in different clinical settings in the general population. So this is UK Biobank population, and they show that patients that have a polygenic score in the top percentile, so 1% of the population, they have a threefold increased risk of being diagnosed with HCM over time from birth. And the absolute risk is actually not negligible. It's up to 2-3% around age 60 or 70. So that's interesting. Whether we use it in population screening, we don't know yet because we don't have any disease-modifying therapies, although that might come one day. Another setting which is quite interesting is what I mentioned earlier, the penetrance of sarcomeric variants. So this is a general population, the UK Biobank populations. There were 640 carriers of pathogenic HCM-causing variants, and they show that among the lower polygenic score quintile, the penetrance is about 1 to 2%. And if you go to the top quintile, so the top 20% of the population, the penetrance goes up drastically between 15 and 20%. The potential here, and this is yet to be shown, is that we could use that to better counsel patients that undergo genetic screening for family history of sarcomeric HCM. So instead of telling them, yes, you carry the variant, or no, you don't carry the variant, if they carry the variant, we could tell them, well, yes, you carry the variant, but you also have a high polygenic risk, meaning that you have a higher likelihood of developing disease over time. So potentially useful for genetic counseling. And then the more striking and I guess disruptive finding of the group was an association between polygenic risk score and mortality in patients who are diagnosed with HCM. We need to follow up and validate this. It was done in 2 different data sets with HCM, so UK Biobank at the left and Genomics England at the right. And we show that polygenic risk score in the top 80%, in the top quintile is associated with a 4 to 6-fold increase in death risk over time. No correction for clinical parameters here. So it might be that most of this polygenic risk score association is captured by traditional clinical risk factors. So what are the next steps before clinical implementation? We're not ready to apply it in clinical practice as of now, but so there's some work to be done. First is demonstrating the added value of PGS on top of standard clinical predictors. So there's international studies that are ongoing. HiRO HCM is one of the studies that will be tackling this. TGH with Arnon are contributing a massive number of samples with clinical data to that study as well, and also including some sites in Europe. So we anticipate about 5,000 patients with HCM or carrying sarcomeric variants, where we will study whether PGS on top of standard clinical predictors is at all useful to predict risk in different complications. The second next step is to optimize and test PGS in diverse populations. It's a big issue in polygenic risk scores. And so it's quite challenging. We know that polygenic risk scores do perform in non-European populations, but their performance is much less. So there's some work to be done here. And my message to any research coordinators or clinical staff here is please enroll all your non-European populations in HiRO and in other studies because that's important to tackle this major issue in terms of diversity. And the last is to the knowledge transfer to cardiogenic diagnostic labs. Polygenic scores is a completely different beast than sequencing to identify rare variants. And so we currently have funding from Genome Quebec to try to implement this in the clinical practice in our institution, the Montreal Heart. It's a proof of concept feasibility study. We're not doing it for everyone, but targeting to report the first polygenic scores in cardiogenic conditions in a clinical setting, diagnostic lab, sometime in early next year. So that's our time. And this kind of all evolves at the same time, the knowledge transfer to the diagnostic lab, and at the same time trying to advance knowledge about the potential use of polygenic risk score. I hope I didn't go much over time.
That was amazing.
Thanks, Jason.
Any questions from the group? Yeah.
Question.
Great talk, Rafik. I really enjoyed it. One of the questions I always have when reading about these papers, polygenic risk scores, is, I mean, we as of now, we treat these polygenic or polygenic scores as a once in a lifetime static feature. I think, and it's not based on much, but just when considering the field of epigenetics, isn't it likely that the polygenic score of an individual for a disease might be dynamic and evolve over time? Because one of the questions is, you spoke about, I mean, now we're speculating about future population screening. How often do you do that? Do you do it once? What are your thoughts about that?
So the polygenic risk score is based on DNA only, so DNA sequence. So it doesn't change over time, but of course the risk attributable might change over time.
Yeah, but
the actual
epigenetics.
Yeah, of course. No, but the actual score, I mean, the number, if you use the same SNPs and the same weights, you'll always get the same number. DNA doesn't change over time, generally speaking, except for gene therapies and CRISPR-Cas. But I agree with you that, you know, the risk attributable to a certain polygenic risk score percentile might change over time, but this is not explored at all in the cardiogenetic conditions we're interested in. So I don't have any answers based on data. Interesting concept.
I just have a question about your recent or your paper that's about to come out with the monogenic and polygenic risk scores combined. You said you were seeing a penetrance of 15 to 20% on the high end. That seems low. Was your population age lower?
It's a very good question. And sorry, it went fast. So that's a general population. So that's UK Biobank. Oh. And UK Biobank is also a bit probably healthier than the general population. And so these are the equivalent of patients who would go for a direct-to-consumer testing, not having any cardiac issue, and they have a sarcomeric variant, and then they come to you asking whether I will develop HCM or not. So this population. Yeah.
And that's really important in terms of penetrance in a family that has disease is going to be much higher for the same variant than in a general population where there is that family doesn't have disease, because their genomic background, the polygenic risk score in the family that does not have disease is going to be really low. So the disease threshold charts that he was showing, you just have the pathogenic variant, but not the other points to get to 100.
And to answer your question, Susan, I mean or your comment, it also works within families. So we have some data that suggests that penetrance within families are associated with the polygenic risk score, which has important implications from a potential gene therapy, gene editing perspective. If we decide to go and offer the therapy early on before the disease manifests, it will be key to have biomarkers like polygenic risk score to predict which individual will develop the disease or will develop severe disease or complications related to the disease. So that has a lot of implications, and some of the gene therapy companies are interested in this topic at all for a prediction perspective. Thank you. Thanks, everyone.